Okay, so this is showing you how we do our operative records, or keeping operative records. So I pulled a chart from a surgery that we just recently had last Friday. I did not work this particular surgery. It was an exploratory surgery, an emergency exploratory surgery on a 10-year-old boxer who acutely started showing signs of what the doctor wasn't sure if it was cancer or not, but the radiographs she thought maybe there was a mass on the liver or spleen. She wasn't sure, but she thought she maybe saw a mass. So anyway, we did an exploratory surgery. So I pulled this chart. And like I said, I did not work this particular surgery, so the anesthesia log is not filled out ideally. So it's got a whole mess of stuff. The girl ended up running out of room because the surgery took almost 2 hours long. This is essentially how we fill it out. So in the top area we have the patient information, date of birth, weight in kilograms, so we can quickly convert it. What type of surgery, the doctor who performed the surgery, and the anesthetist, or anesthesia technician rather, who is filling out the log. So in the second block we have our drug information that we used, and I'm going to go ahead and add this as well. These are not your ideal anesthesia logs. These are ones that the doctor kind of made up for our particular office, just because we don't, in his opinion, it's not necessary to keep track of end-tidal carbon dioxide and that sort of thing. So, I mean, obviously we keep track of heart rate, respiratory rate, the temperature, and what we keep for maintenance and for anesthesia, and the fluid rate, obviously. So that's what that is right here. And then we have what we put them on as far as a rebreathing system or non-rebreathing system, what size endotracheal tube. And then down here we have the monitoring aspect of it for surgery. And that's done every 5 minutes, and you see that this anesthesia technician actually did it about every 5 minutes, and she ran out of room, and so she just ended up crossing out the recovery area right here down at the bottom, that's where we keep our recovery area, at the bottom of the anesthesia log. And she just continued the monitoring down here. But ideally, once we get done with surgery, this is what we keep it on. Once we get done with surgery, ideally it's done in this time period. So once we're done, we come down here and we start filling out the patient's anesthesia log to kind of keep track of, is their temperature coming up from surgery? Is their color starting to pink back up? Because even though they're on anesthesia, their temperature is going to drop because of the anesthesia. Regardless of the warming measures that we take. During anesthesia, during surgery, there's only there's only so much that you can really do, especially if they're having an exploratory surgery. You can't put a warm circulating hugger on the patient because it's going to affect the sterile field. So the most we can do is warm fluids and the warm circulating water pad that we have underneath them. So like I said, we keep track of the patient's temperature as they're coming out of, as they're recovering from surgery, and check their mucous membranes, their color, the capillary refill time. We check if they're alert yet. Are they rolling over from a a lateral recumbency to a sternal recumbency? Are they like becoming more aware of their surroundings? And then we start to mark down like about what time they become ambulatory, meaning when are they starting to try to get up and try to walk, that sort of thing. So, and then we initial who is keeping track of this. And then down at the very bottom, we write down what measures we took to keep the patient warm during all this time. And but this is our anesthesia log that we do. Most other offices, their anesthesia logs are a lot more in depth. They would, obviously, like I said, we do keep track of, what time we took, the heart rate, the respiratory rate, what their temperature was, what their mucous membrane looked like, and what their capillary refill time was, what percentage of isoflurane we put them on, what percentage of oxygen we put them on, that sort of thing, and their fluid rate. And we also keep track of the anesthesia start and when we've turned off the anesthesia machine. Obviously we keep the oxygen flowing for a while to keep the patient oxygenated, but if we turn off the anesthesia, we want to know how long has the anesthesia been off, and then we keep track of how long surgery was, surgery start, surgery stop, and then intubation time, when did we intubate the patient, when did we extubate the patient. We keep track of things like that. So it's just kind of a thing. It's more of a what would be the word I'm looking for? It covers you, really, essentially. That it keeps you better with your, trying to figure out what it is I'm saying. Your operative records are well kept if you do this way, so that way, you know exactly, if anything comes into question, you know exactly what to say. Well, these are the answers. This is what happened at this time during the surgery. This is what the patient's heart rate was at this time. And, it's important for a technician to know the normal parameters of heart rate and respiratory rate of the animal, especially for that size of the animal, the patient. And but like I said, this is just our anesthesia log that we use. Most other veterinary practices will use a more in-depth anesthesia log where it'll have a checklist of different things to have marked off. Did you lubricate the eyes? Did you attach this type of monitoring system? What kind of pre-medication did you use? What kind of induction did you use? Which we do keep that on our log form, but others are a little more in depth. Some actually have in case of emergency type situations, say the patient the patient ends up becoming too bradycardic. Well, for pre-medication, the patient was not given any atropine. Well, in case the patient does become bradycardic, you want to know how much atropine should I give this patient, and that would be something that you would but how much you would calculate beforehand, so that way you know if this should arise, I know how much to calculate or how much to draw up, because I've already calculated it up and I put it on the chart, and it's there for me to see. Well, the patient's heart rate is dropping a little bit, no matter if I adjust the anesthesia or not. I might want to go get some atropine right now and give it to the patient during surgery. And another thing, like I said, we keep a good records of what it is that we use, pre-medication, induction. We even have a little space right here in case we want to add anything as far as pain medication goes. That's what we use, and what kind of drug it is that we used, the dosage, is it in milligram form or is it in milliliter form, and what route, IV, subcutaneous, or IM. What route did we use? So, like I said, this is something that we created for our office, this particular chart, but there are others that are a lot more in depth. But it's important to keep track of these because, like I said, it's more of a liability. That's the word for it. That's what I'm looking for. But once surgery is done, depending on these different medications that we used, most of them are going to be controlled substances, so we want to log them out. And this one, like I said, this is an early surgery from last week that has already been logged out. All this information has been logged out. So these are our log out forms that we use. Has the patient's information and what the date, what type of surgery, and the weight of the patient. And did we perform any blood work? That's another thing that's on the more in-depth anesthesia log forms. Did we do any blood work? That sort of thing. That's on the checklist. Again, our doctor thought that it just isn't pertinent to our practice as far as the anesthesia log forms. Again, it does the pre-med. Well, this patient was pre-meded with atropine, and then induction, ketamine, midazolam. And we actually go ahead and log it out right here. Ours is A134. Oh, and I didn't see it, but butorphanol. The patient was also induced with butorphanol. And A7. And midazolam was A108. So these are things that we've already done. We've already logged them out. And then the hydromorphone, obviously, meloxicam was not a controlled substance, so it doesn't necessarily need to be logged out, but we put it on the chart just so that way we know, it's there for record keeping, or record sake rather. And we put down that we put the patient on isoflurane for maintenance. And once this is done, once we log out the forms in our office, there is a book that we use to log out. I've seen it before, but because of my position at this particular practice, I am not allowed to physically log out any drugs except for these sheets. I'm not allowed to touch the books. So that is our office manager's job or a doctor's job. And so once I fill out the log out form, then the office manager or doctor will go back and balance out our log out drug, or logged out drugs. And we have each one specifically for that drug. Like one is for ketamine, one is for midazolam, one is for butorphanol. And but essentially what it is, it's the same as it says in the textbook. It's just the name of the drug, the patient, the client name, the date that the drug was used on, and how much of the drug was used, and who logged out that drug. And so essentially you have your starting point of your drug, how much you had to from the very get-go, and then so far, or as you go, each patient who gets given or administered that, say ketamine for instance, gets administered ketamine, you subtract that amount from your starting point, and you should, once you get to 0, then boom, we go to a next bottle, that sort of thing. But that's essentially how you log it out. Like I said, I'm not allowed to show you our log out books. Those are locked up, so people can't mess with it. I know it sounds stupid, but we've had issues in the past where people have not logged stuff out correctly. We have had people lie about logging stuff out. It's stupid, I know, but and so because of that, I'm not allowed to touch it. So I'm not going to ask any questions about that. But that's essentially how it is, how we do things in our office. And like I said, I really wish that I could show you a more in-depth anesthesia log, but that is how you do that. And essentially, if anything as far as drugs go that you weren't sure of, the doctor will always write it down in our charts, in our patient's chart. So for instance, this is the back of our patient's chart. It's like a book, pretty much. We are not paperlight by any means. We use lots of paper in my office. So this is just only half of the patients for that day for surgery. So yeah, we see here that he came in for just an exam. We ran blood work, and then we ended up essentially doing an exploratory surgery. And this is the doctor's notes about the surgery. She did hers a little backward this time. Usually they do the medication at the very beginning of their notes. But you see here where the doctor wrote down IV hydromorphone, and then meloxicam sub-Q, and then the pre-med and induction that she gave, and an IV catheter. So if we have any questions about like our logout sheets, we would just revert back to the patient's chart and just go through. Well, the doctor used 1.4 mils of atropine. Oh, and butorphanol. They did not use butorphanol as induction. Sorry, that was a mistake. So atropine and butorphanol. So that's the pre-medication. And then the doctor used ketamine and midazolam as induction. And that's essentially what they wrote down. Atropine, butorphanol as pre-medication, and then for pain management they use meloxicam and hydromorphone, and then induction they use ketamine and midazolam. So we want to make sure that everything matches essentially. And I'm going to go put this back in our logout charts book, and that's really how you log stuff out and keep operative records of each patient, and that way everything matches, everything, keep good records. Good record keeping is key. If you have any questions, refer back to the patient's chart.